I'll make a start then. So good evening and welcome everyone. I'm Maria Morgan, President of the British Association for the Study of Community Dentistry, or BASCAD for short. I'd like to welcome you to the second session in our series of masterclasses, which aim to offer mentorship and key insight into public health, dentistry and strategic health leadership from past presidents of BASCAD. I'd like to thank Colwyn Jones, who was a past president of our society between 2007 and 2008, for agreeing to share his knowledge and experiences of National Oral Health Improvement Programme, ChildSmile. And after all, health improvement is a core activity of BASCAD. Thank you, Colwyn. On our panel this evening, we also have Dr. Charlotte Jevons, our BASCAD Council Lead for Oral Health Improvement. And to kick off proceedings, I would like to hand you over to Ross Keat, who has organised the sessions, our early stage career council member and specialty registrar in dental public health. So Ross, if I could hand over to you.
Thank you very much, Maria. Just to echo what you say, thank you very much, everybody, for coming. And thank you very much to Charlotte for joining us on the panel today, and Ilona for helping out again with some administrative duties in this session. So just a little bit of housekeeping before we get started. Could I please ask that everybody keeps their microphones and their videos off during the presentation for a number of reasons, but it's just so Colwyn's presentation goes smoothly, and also the session has been recorded for the BASCAD YouTube, so you don't want to have any embarrassing moments enshrined on there. We are going to have a question and answer session at the end, so feel free to use the chat box whenever anything springs to mind, and myself, Maria and Charlotte, we're going to be looking at the chat box throughout and start sort of collating themes about around the questions which are asked, and then we'll pose these to Colwyn at the end. We did have an awful lot of questions at the last masterclass session, and the plan is with those that we're going to put all the questions to the people who've run the masterclass sessions, and hopefully get answers to all the questions that have been asked. So whether that's done in a video format or it's done through a text question and answers, we're not quite sure yet, but we are going to answer all the questions that are asked during these masterclass sessions. So on to our presenter this evening. So it's Honorary Professor Colwyn Jones, and Colwyn retired from his NHS position as Head of Evidence for Action Team and Consultant in Dental Public Health within NHS Health Scotland in February 2018, but he continues to work part-time as an Honorary Senior Lecturer at the University of Edinburgh and an Honorary Professor at the University of the Balearic Islands. He's the Dental Advisor for the Falkland Islands Government. He's been a member of the Faculty of Dental Surgery, Examiner at the Royal College of Physicians and Surgeons, Glasgow from 2003 to 2018, a member of the Intercollegiate Specialty Fellowship Examination in Dental Public Health from 1999 to 2014, and a chair of the Intercollegiate Specialty Fellowship Examination in Dental Public Health from 2014 to 2018. He's a member of the British Fluoridation Society, the Oral Health Foundation, and has been a referee for the British Dental Journal, Community Dental Health, the Journal of Disability and Oral Health and Dental Management, BMC Oral Health, and the International Journal for Circumpolar Health. Colwyn is a qualified ski instructor and a keen mountaineer when he finds time along all these other activities. Importantly for BASCAD, he was the president of the association in 2007, and he also has been the president of the European Association of Dental Public Health from 2017 to 2019. So without any further ado, I'm going to pass you over to Colwyn to give this masterclass session this evening relating to the ChildSmile in Scotland. Thank you very much.
Okay, ladies and gentlemen, thank you very much for inviting me to come and talk today. I do hesitate to think of myself as anyone that can give a masterclass. I was a jobbing NHS consultant in dental public health, and I always hesitated to provide advice or give advice to my colleagues. However, having retired a couple of years ago, I feel it was quite nice to be asked back to talk about what we've been doing in Scotland here. So as you've heard, I was the BASCAD president in 2007 and 8, and this is what I was doing before COVID struck back in March of this year. This is a mountain in Switzerland, We'd just been to the summit and we were heading back down. COVID had closed all the ski resorts, and so that was the end of our ski season. If you recognise the mountain, yeah, if you want to guess what it is, you could maybe guess in chat, and we'll have a look at it afterwards. What I'm just going to talk about today, I'll talk about my my own progress through dentistry and incidental public health, some of the things that inspired me or gave me inspiration and so on. I do have a few other mountaineering pictures to share with you, stories to share with you, and then we'll move on to looking at child dental health in Scotland and the ChildSmile programme. So those are that's the kind of outline I was going to use today. It's a COVID-19 free presentation. I retired before COVID hit. I did volunteer to give some inoculations, injections and so on, but I was never called on to give any. But anything I say tonight is really pre-COVID, so please bear that in mind. I think that's probably just the way to look at it. This is the background here is my COVID passport. I've been vaccinated twice, and this is an NHS Scotland COVID passport. It's not that I can go anywhere with it, or perhaps could get to Portugal if I could book some flights, or the Falkland Islands, or wherever. But at least I've been fully vaccinated. And the NHS did this for me for free in Scotland. This is from the NHS Act, the National Health Service Act, 1946, way back then. And this is the opening line from the original Health Service Act. It shall be the duty of the Minister of Health to promote the establishment of a comprehensive health service to improve physical and mental health, and so on. And it just takes me back. Every time I read this, it makes me realize the the inspiration behind the National Health Service. And back in those days, they really knew how to enact legislation. There's no doubt about what they were trying to create here. And that Minister of Health was a chap called Aneurin Bevan. He was a Welshman. And this is a quote from from him as he was trying to persuade people to adopt the National Health Service. And I just think it's a great quote. There is not even a hint of victim blaming in this particular quote here, something that I fully agree with. And this is a cartoon that was in the Evening Standard, a newspaper. For the younger members of the audience, newspapers is where we used to get our information and news many years ago, before the internet came along. And this is from 1948, just as the National Health Service was about to start. This must have been a typical representation of a dentist here. It doesn't look like a very comfortable position to be working in. And the kind of professional position was that the National Health Service is going to steal money from dentists and also from doctors, but it was particularly dentists who were highlighted in this cartoon. So the two things I take from this is that, or two things I object to in this particular cartoon. I fully supported the National Health Service, was the idea that dentists had pockets full of money. And the second one is this idea that dentistry is going to hurt a little bit, I'm afraid. But that was the start of the National Health Service back in 1948. And here I'm up in Edinburgh, about 55 degrees north, almost 56 degrees north, the same latitude as Copenhagen and Moscow. And as I look out, it's not raining at the moment here in Scotland, but you needn't worry. If it's not raining, it will be shortly. And within Europe, we've had a little bit of turmoil in Europe over the last couple of years. But I was the European Association of Dental Public Health president up until last year, a couple of years ago. And I would recommend to you that you can become a joint member of BASCOD and the European Association of Dental Public Health. It's £20 more expensive, I must admit, but that gives you access to all of the European Association activities. And remember that this subscription you can claim it back against tax if you're a dentist. So the European Association of Dental Public Health were very keen to work with BASCOD, work together there. And this is a quote about working with our European neighbours, and about it may even be worth losing a bit of national sovereignty to do that. This is probably a little controversial for some people. It was actually Winston Churchill who said this way back quite a number of years ago. And another cartoon. This is, I've got to thank my colleague and friend David Conway in Glasgow for this cartoon. Brexit in 2016, the UK overall voted 52% to 48% to leave the European Union. However, Scotland didn't. About 2/3 of Scottish people voted to stay in the European Union. So a lot of Scots feel that we were being dragged out. We were dragged out. We've gone. We were dragged out of the European Union against our will. There is one flaw in this cartoon. I don't know if you've seen it. It's that Northern Ireland voted to stay in the European Union as well. So in Scotland, well, not quite 2/3, 62%. There we are, a bit of fake news there. Almost 2/3 of Scotland. Where I live here in Edinburgh, in the capital, 74%, 3/4 voted to remain in the European Union. And in the constituency I live in here, Edinburgh South, I can't remember if that's the Westminster or the Holyrood Scottish Parliament constituency, but 78%, almost 4 out of 5 of people in this area. So I'm an unabashed and unrepentant Remainer, whatever you want to call me, even if it's just to stay in with stay friends with my neighbours here in Edinburgh. And I really enjoyed Richard Watt's masterclass, I think about 2 weeks ago. And we both qualified at the Edinburgh Dental Hospital and School. Richard was a couple of years after me. And this is a photograph taken recently at the dental school. It's now closed, unfortunately. I don't think the closure was related either to my passage or Richard Watt's passage to the dental school, but it's closed now. And as you can see here, it's a pub. Well, pub's a bit, probably a bit down market, a cocktail bar and kitchen. And they've even got pavement seating outside. Downstairs is the kitchen downstairs where you can dine, which is where I did my prosthetic setups down in the prosthetics lab that Richard mentioned last week. And just to add to the picture, the guy walking past, I didn't get his permission to photograph, but he's smoking a cigarette. So smoking and drinking, the new activities of the Edinburgh Dental School, unfortunately. This is actually my master's graduation photograph. My undergraduate graduation photographs were just too embarrassing to put on screen. So this was my master's in Manchester when I did my higher training, just to show I did actually graduate. And I actually quite enjoyed doing prosthetics, setting up dentures and so on. It was in wax. You could go back to them. So even if you hadn't done a very good job, you could go back. It could be an iterative process. And I quite enjoyed setting up. It taught me about occlusion, about the curve of Spey and the curve of Wilson and all the rest of it, how teeth occlude and so on. And when I was a clinician, I also enjoyed making dentures. To me, it was something that could transform somebody who was entirely edentulous. You make a new set of dentures, you fit them for them, and it was almost transformational. So I did enjoy being a clinical dentist. It wasn't because I particularly hated it or anything that I moved on to dental public health. But there were just occasionally things that came up. This was the edentulous from surveys many years ago now, looking at edentulous in different social classes in the UK and in Scotland. The green is social classes 1, 2, and 3. Non-manual, blue is 3 manual and 4 and 5, social classes 4 and 5. And you can see there's a very well-established social class gradient there using this classification. And in Scotland, we've got even higher edentulous rates. And I was puzzling over this. I couldn't work out. I mean, these were the same occupations that people had in England and in Scotland. There was something going on here that I couldn't understand. My understanding of this was meager and unsatisfactory, which is a quote from somebody I'll show you in a minute. And I realized it's because we've got higher levels of poverty in Scotland. That was the explanation for this. And Richard Watt in his masterclass talked about the WHO report that Michael Marmot chaired, the social determinants of health. And these unfair and avoidable differences in health status really created by the different levels of poverty that we have in our societies are the issue. This is something that's captured my imagination and driven me on here. And up here in Edinburgh, this is a statue of Adam Smith in the Royal Mile, just next to St Giles Cathedral there. And Adam Smith was the father of the market economy, the guiding hand of the market, of capitalism. But when you go back and study what he said, one of his quotes from him is, "No society can surely be flourishing when members are poor and miserable." So Adam Smith saw the market as a way of improving the situation for the poor and miserable in society. And there's something about the capitalism we have now that doesn't spread the rewards of capitalism quite widely enough across society. This is a graph from different European unions, different European countries, I beg your pardon, the European Union. You probably can't read the names at the bottom there, but there's whatever there are, 27 countries. This is back in 2016, and it's looking at children who are brought up in poverty across the European Union. And I can't imagine, I don't imagine anybody listening today thinks that children growing up in poverty, you know, their education will suffer, their health will suffer, everything will suffer. And in the European Union, we've got 26% of children still growing up in poverty. The European Union is probably, I don't know, I should have checked, it's probably a fairer society than the United States of America and other places. But the fact that we've still got a quarter of our children growing up in poverty in the European Union. And if you look at the UK, we're actually worse than the European Union. We've got the 5th largest economy in the world, in the United Kingdom. And we've got more than a quarter of the children growing up in poverty. It's a shocking finding, and it's probably got worse since 2016. And we should be aiming towards the left hand of this graph, to looking at the countries, Denmark, Finland, Sweden, and so on, why they've got such low levels of child poverty. We should be learning from them. So this was from 2006. And this is the United Kingdom. It's looking at child poverty since 1960. It goes from 1960 to 2020. And I've added in that figure from the European Union in there, the 27%. And you'll see that way back in 1960, between 1960 and 1979, that the level of child poverty was only 15%. It was about half of what it was in 2016. And this is when I grew up. I was a child, I was 0 to 17 at this stage. So I grew up when child poverty levels in the UK were much lower than they are now. And you can see that around about 1979, the percentage of children growing up in poverty rocketed. It doubled, it more than doubled. It then leveled off, declined slightly, and since the the crash 10 years ago and so on, the prediction is that the level of child poverty will rise again. So that child poverty, it's not inevitable. It's something that happens when governments make policies. And between 1979, that was the year that Margaret Thatcher became the Prime Minister. Ronald Reagan was the President in the United States. And during that period, child poverty rocketed. It kind of leveled off in the John Major years and so on. There was a slight improvement. It did go down when Gordon Brown was the Chancellor, Tony Blair was the Prime Minister, but it didn't go down consistently. And recently, with austerity, it's increased again. So these are the unfair inequalities that we have in our society, and they don't need to be there. They're there because of government policies. And statistics for me, dental public health, dentistry, statistics have always been something, initially they were hard to understand and so on, but I did persevere with it, and I quite enjoy statistics now. I'm one of these sad people that enjoys listening to more or less on Radio 4. There are no certainties, only probabilities. There are some things that have a probability of 1. We know they are going to happen. We're certain they're going to happen. The two obvious ones are death. We haven't conquered immortality. The second one is taxes. And probably a third one that this audience knows is that there'll almost definitely be another reorganization of the National Health Service within the next few years. But statistics to me are, and using statistics, it's all about the evidence base, accurate statistics, and using statistics correctly. You know, over the years I've started to be more careful about them and choose to use them. This is a character that I quite often quote. I don't know if anyone will recognise him. It's Lord Kelvin. He was a physicist at the University of Glasgow, became a Lord. He sorted out, I think it was the second law of thermodynamics, degrees. He became Lord Kelvin, and the measurement of absolute temperature, degrees Kelvin, was named after him. But one of his quotes is, when you can measure what you're speaking about, you know something about it. And when you can't measure it, your knowledge is of a meager and unsatisfactory kind. And I'm not knocking quantitative research, but qualitative research. This might sound a bit positivist, a bit quantitative, but I think if you're going to try and talk to people about things and express things, you have to be able to talk about them in numbers, as well as the qualitative side as well, trying to influence people. And where we should be getting this information is from our journals. This is our specialist journal, Community Dental Health Journal. You can see BASCOD and the European Association share the journal. I've been the associate editor, and I think the quality of the papers that we get in community dental health are excellent. It's quite hard to get published in this journal, actually. We get a lot of submissions. And this combination of publishing and statistics, I'm just going to take you through the first bit of dental research that I got published. I'd had 1 or 2 case reports published, but this was the first research that I'd done. And I was working with children a lot of the time. I was very keen to give pain-free injections, or try to give pain-free injections using topical anesthetic and distraction techniques and so on. And while I was working in the community dental service, I just sat down one day and decided to get the patients to report back how much pain they felt during the administration of the injections. And I collected all sorts of other information as well, anxiety scores, and how painful the treatment was, and so on, and measured how long the injection took, how long the treatment took. And I ran this, I think it was for about a month. I had over 300 patients that had a local anesthetic, 308 patients. I had all these bits of paper, and I sat down with a chap called Alan Gerish, who was the Chief Area Dental Officer in Argyll and Clyde Health Board at the time. He had a computer in his office. He was very advanced. Not many of us had computers in those days. And he had a software package called Survey Plus, which was one of the first dental software packages for collecting dental epidemiology. Some of the older members may remember this. It had been written by a BASCOD president, a chap called Tom Dowell, who had gifted the rights to this software program to BASCOD. It was an ancient DOS-based system. And I entered all this information and into this ancient software. And I can remember there was you could plot the information. There was a graphics side to it. It was very basic and so on. And this table, the information was in there, and I plotted out this graph. And I can remember it coming up on the screen, and it just knocked me away. It's the fact that the longer you took to give the injection, the less pain it was. It confirmed what I'd always suspected, always thought, and you know, I'd kind of come up with this at the time, but very naively, I thought I'd come up with a system that you should be taking trying to give painless injections and trying to take as long as you could basically over the injections and so on. I realize now that the study was fatally flawed. It still got published, but there were flaws in the way that the study was done. I didn't even have ethics approval for this study. It was so long ago you didn't need it. But it did get me published, and it did get me interested in doing research. And I still get a kick from when you finally put all the information in and you analyze the results. It really gives you for me anyway, it gives me a great inspiration to get a bit of research done. And when you think about it, or when I thought about it, when you were applying for jobs, what was going to make me different from any other person that was applying for those jobs was if they had something extra that they could show, a research paper, case report, something that had been done, a further qualification. You know, if you wanted to get on, you know, it just seemed to me the obvious thing to do would be to publish something. Overall, the paper showed that when I give a local anaesthetic, it didn't fail completely, but it was only partial anaesthetic in about 20% of my cases. Almost a quarter of my inferior dental blocks were not perfect. And I suppose what this was really an audit of, this is the baseline audit. Of course, I didn't go back and repeat the cycle, so I didn't complete the audit cycles, but I suppose that's how I would have got it past an ethics committee these days, in that I was auditing something I was doing already. And there's lots of things out there, things that we do that haven't really been researched properly. I would encourage you to think about, the younger members anyway, to think about going out and researching some of these issues that are still problematic in dentistry, shall we say. And I worked in general dental practice. This is my brass plate. I dug it out yesterday and polished it up a bit and took a photograph of it in the garage, just to show that I did work as both in the community dental service, hospital service, and in general dental practice as well. And this was on when I worked up in Fort William, way up in the north of Scotland. This isn't Fort William. This is just in the mountains, just to the south of Edinburgh. But working in Fort William, it was in the mountains, and it was great. Clinically, it was by far the best time of my life there. The people were just normal individuals coming in for the dental treatment, and I thoroughly enjoyed working as a dentist up there. But things changed. There was a new dental contract was coming in around about 1989, 1990, and I returned back to work in the hospital service in Paisley. And this was January this year. These hills are just over 600 meters high within the COVID restriction zone in Edinburgh here. So I was able to go skiing this year in Scotland. And down at the bottom there, that's one of the reservoirs that feeds Edinburgh. So if we ever get fluoridated water in Scotland, that'll be one of the reservoirs that gets fluoridated. But, I suppose the other thing I was going to say, I managed to go skiing in my lunchtime when I was working in Fort William. Didn't happen very often. But anyway, all the fun had to end, and I eventually applied to become a dental public health trainee. The science and art, the science is the evidence base, and the art are the influencing skills of dental public health. And I went down to Manchester. I got a job down in Manchester. In the Northwest Regional Health Authority down there. Thoroughly enjoyed it. Manchester's a lovely city. You know, I do miss Manchester sometimes, but working in the dental school there, I met lots of people, and the medical school there. I met lots of interesting people. I learned a lot from them. But the two people I really have to thank were the two consultants who supervised my training down there. They were absolutely great. The gentleman on the left is Keith Woods. Keith sadly passed away just a few years after he retired. And he worked up in Lancaster, up in Preston, at the North West Dental Public Health Resource Centre. He was good with computers. He was good with epidemiology. He was fantastic to work with. He was also fantastic at squash. I was 20 years younger than him, and he used to absolutely thrash me at squash. I was, you know, I used to play for the dental team at university, but absolutely humiliated you. Apparently, you have to pay a lot to be humiliated like that these days. And the other gentleman is Jeff Taylor, who I'm sure many of you know, down in Tameside in Ashton-under-Lyne in Manchester there, who then went on to become the postgraduate dean. Two very different characters, but two people for whom I can only thank. Dental public health to me really was comfortable. I felt comfortable as a dentist, and when I moved into dental public health, I knew I'd made the correct decision. For me, it was without doubt the best career move I've ever made. And I can remember the first week, after the first week working in Ashton-under-Lyne with Jeff, and there'd been various orientation meetings and so on. And Friday, just before lunchtime, Jeff had the adjacent office. He walked in and he said, I was going to go for a pub lunch. Do you want to come for lunch? And my response was, I was actually going to go for a jog. And as it turned out, I did actually go for lunch with Jeff that day. And subsequently, I have to say, I've often gone to the pub with Jeff for lunch and for other reasons. But in all the years that I've known Jeff, I have never once managed to get him to go jogging with me. There we are. As I said, I really enjoyed being a trainee. It was 4 years where it was just fantastic what I learned. It was great. I just soaked it all up. It gave me the opportunity to do some more research. And this is a paper that I got published whenever it was back in 1997. It was actually after I'd finished work, but finished training. And it was looking at fluoridated Newcastle and naturally fluoridated Hartlepool. These were electoral wards. Each of the dots, so the triangles, is an electoral ward. Salford and Trafford's non-fluoridated, Newcastle's fluoridated, Hartlepool is a positive control. It's got natural fluoridation at 1.2 parts per million, just showing that the inequalities gradient flattens off with water fluoridation there. And I got this published in the British Medical Journal. The Newcastle data came from a chap called David Evans, who's again now retired, was up in Newcastle, and the Hartlepool data came from the consultant up there, David Trotter. David Trotter provided me with the Hartlepool data. These were census surveys that were done in these areas. And various other things I was able to research when I was in my training was capitation registration. Is there an inverse dental care law? Of course there is. There's no reason why not. And this was looking at the percentage of the population registered. It's just using another deprivation index, the Department of the Environment Index. These are district health authorities across England. You can see the R squared there. So 40% of the variation in the child population registered is explained by poverty, essentially. And it's not a straight linear regression line. It's a quadratic regression line or something. And it shows that the more deprived you get, the more you go to right hand, the fewer are registered. You really get a drop off with poverty there. In the capitation registrations, for some weird reason, they used to lapse every January, on the 1st of January, if the child hadn't been for treatment in the last 18 months. And again, the lapse rates have got an inverse care law there. And the more deprived, you can see the graph swinging up there. And it was great to be able to do all this work, to find out all of these things, get them published and so on. But the overwhelming thing I found for a lot of the research is that poverty was the main cause, the main problem with influence on health and so on. And again, this is a quote from that World Health Organization paper report that Michael Marmot did, Social Injustice is Killing People on a Grand Scale. And it's probably got worse since the austerity was introduced, and it's probably got worse with COVID. So when I was BASCOD president, inequalities were the theme of the conference I had up in Edinburgh. I was working in Edinburgh by this stage, and this is at the conference dinner just before we went in there. Just to prove I'm a Scotsman, I've got the BASCOD medal on there. And I found that if you wore a kilt, you tended to get a lot of attention. So guys, get yourself a kilt if you want a bit of attention. Sue Gregory here, the retired Deputy Chief Dental Officer. I think that's Sandra there, just to her right. And Martin Downer there, who's again is sadly not with us. And I don't know if you can see behind me there, that's Andrew Rugg-Gunn. And he's wearing a kilt as well. So I didn't realize there was a Rugg-Gunn tartan, but there must be. I'm wearing the Jones tartan. But the most upsetting thing about this was that Andrew had much better legs than I had. Anyway, this was the presidential conference that I had in Edinburgh back in May in 2008. This is a map. It's not the COVID travel regulations. This is looking at 5-year-olds. It's just a traffic light. Green is where less than 35% of 5-year-olds have got experience of tooth decay. Amber is between 35 and 69%, and the red is over 70% of 5-year-olds. So this dental caries is still a major problem across the world. But there are some areas where things have got better. Greenland here, it's certainly looking at the map, it's the largest area. And just after the conference finished on the Friday. The Saturday I was at home. On the Sunday I flew from Glasgow up to Iceland on the Sunday after the conference, and on the Monday after the conference I flew from Iceland up to the east coast of Greenland, and we chartered a plane. So 3 days after the BASCOD conference, I was up in Greenland. I was up at the top here, these, I can't get the pointer to work, here it is, up in the Stounings Alps, which is a coastal mountain range. And we landed there in this twin-engine plane. This is the Havilland Twin Otter. They stopped building these about 50 years ago, but they're apparently they're aircraft that just keep flying. If you look at the size of the wing on that, it's absolutely enormous. I don't think there's any doubt that that plane is going to fly. And we'd flown in, we'd landed on the glacier. This plane has got skis on it. And once we'd come to a halt, the nose wheel with the ski on it sank into the snow. There were 8 of us on this trip. We got out, we unloaded 1.2 tons of equipment, food and tents and skis and all the rest of it. And then we had to help the pilot to dig the nose ski out of the snow there. And he took off and left us there on a climbing expedition for a month. So that's what I did after my BASCOD presidency. I don't think the two items were necessarily linked. This is a Google map, a photograph of a Google map, and this is the glacier that we landed on. It's called the Lang Glacier in Danish. That's the Long Glacier in English, and this is where we landed. These were the mountains that you could see behind here. And we climbed all the various mountains up around about. Most of them are highlighted there. But I want to draw your attention to this glacier here. This is a small curved glacier that flowed down here and into the main glacier here. And while I was there, we were the first people to visit this glacier. So I called it the BASCOD Glacier. So BASCOD has a glacier in Greenland named after it. This was us climbing a hill which I named after my mother, Molly Tind, and there's the Bascod Glacier just behind. The hill behind we climbed a little bit later, and one of the guys named it after his wife, I think. So the Bascod Glacier exists. Here's another photograph of the Bascod Glacier down here, curving round here. This is the Lang Glacier where we landed, and the base camp is just off to the right there. I'd climbed up onto this peak, which was named Margaritaberg after one of the chap's mothers. So Bascod's got a glacier there, so I think we've got an interest in making sure that global warming doesn't go too high, otherwise we'll lose the Bascod Glacier there. And I never made it to the cover of the British Dental Journal, but I did get on the cover of the Alpine Journal. This was actually an earlier expedition. I've been to Greenland 7 times now, but this was an earlier expedition to Greenland. And just finally about Greenland, this is a peak called, which I named after my girlfriend at the time, my girlfriend Anne. I called it Ansketind, and it's quite a hard climb to get to the top. And just by chance, one of the other people there were climbing an adjacent mountain and took this photograph. And I don't know if you can see, but there's somebody standing on the top there. It's not me, it's the guy I was climbing with, John. And the good news is that I named it after my girlfriend, and it must have worked because we're now married. So if you get the chance, guys, name a mountain after your wife, after your girlfriend. Although you never quite get the number of brownie points you think you're going to accrue from something. One of the other times we're there, we were traveling back to the coast to a gravel airstrip in a small boat to get back to fly out, and we saw some polar bears. So these are wild polar bears. I was about 25 feet away from them, and they were absolutely amazing to see wild polar bears there. They would have eaten us if they could have got a hold of us, but there was good blue water in between. Okay, so this is a diagram that Richard showed in his presentation last week. I've talked about national and local policy initiatives. As I've shown you, the level of poverty rose because of the initiatives that were brought in there. And for me, dental public health has always been the upstream level, looking at legislation. We've got legislation for water fluoridation in Scotland. It's never been pushed through. Fiscal measures would be things like the soft drinks industry levy or minimum unit pricing. Healthy settings would be what I think is the nursery toothbrushing we've got in ChildSmile in Scotland, down to clinical prevention, the type of things that we're trying to get general dental practitioners to do. Okay, I'm getting a little bit of feedback. I don't know if somebody has accidentally switched on their microphone or not. And again, this is something that Richard showed in his talk last week, the common risk factor approach to disease prevention, where we can use common risk factors to prevent oral disease, but also prevent general disease. But as well as common risk factors, there is a specific risk factor that we have for dental caries, and that's fluoride. And as far as I'm aware, the only thing that fluoride prevents is dental caries. It doesn't seem to prevent any other conditions, sadly. And fluoride, this is the periodic table. Fluoride's up at the top right-hand corner there. It's got a atomic number of 9 next to oxygen, nitrogen, carbon up there. And I'm very concerned. I think that there is an issue of fluoride hesitancy developing. This is just a definition of fluoride hesitancy. It's always been there, I think, with water fluoridation, but we are starting to find it with things like fluoride varnish and even fluoride toothpaste. There are cases where people are refusing to use fluoride toothpaste. And I know that Bascod is keen to set up a group to make sure that We don't have any fake news about fluoride, of which I am hoping to join this this particular group. And if anyone's interested on this, joining this, I think they've called it a hive mind or something, or mind hive. I'd be very keen to hear from you about fluoride hesitancy. But we've got good Cochrane reviews about fluoride toothpaste, and this was the essence of ChildSmile in Scotland is using fluoride toothpaste. We know fluoride toothpaste compared to non-fluoride toothpaste is very effective. The higher the fluoride levels, the higher the frequency of use, the more effective. And we know that using fluoride toothpaste is complementary to water fluoridation from this Cochrane systematic review. And I did do my own toothpaste trial out in the Arctic. We took some toothpaste out there. This is a mountain called Sussex. It was named by Cambridge University, who presumably were at Cambridge College. And these were the participants in the trial, trying out different toothpastes. We tried 3 different types of toothpaste, and they scored them. This is just a simple analysis of variance. And the best toothpaste was Colgate Sensitive Care. I've got no idea. It may be that the toothpaste was very cold. This has got a very intense mint flavour, and it may just be because the toothpaste was cold. It tasted like normal toothpaste. That's the only explanation I can give why. So toothpaste trials, to be honest, it didn't make the systematic review, but there we go. So this is a graph showing the about a 40-year trend in the mean DMFT of Scottish primary 1 children, 5-year-old children in Scotland here. So this is over my practicing lifetime in Scotland, and you can see things have improved in Scotland since I qualified. I can't take all the credit for it, and I probably can't take any of the credit for it. But when you look at this figure, there are 1 or 2 things that stand out in this. You can see there are 2 peaks here which just don't seem to fit in quite right. If we level those off, if we even those off, these were probably mistakes done in the national survey that was done in Scotland in those years, 1994 and 2003. The way the sampling was drawn was probably inaccurate, and that's why those peaks there, they probably don't really exist. We had quite a marked improvement. I've added the OPCS survey, that was Child Dental Health Survey, that was done in 1983 to this. And this improvement was probably due to fluoride toothpaste. This is 1983, so these children were 5, 6 years of age. They had been born in 1977, conceived 1976, 1975. So they probably would not have been exposed to fluoride toothpaste. Whereas by 1988, when the first surveys were done in Scotland, if they brushed their teeth, then children would have been exposed to fluoride toothpaste. So this improvement was probably due to fluoride toothpaste. And you can see that from about 1996, there was a gradual improvement. And of course, everybody says this was ChildSmile. But of course, ChildSmile didn't start until, wasn't fully implemented anyway, until 2011. And some of these improvements were because in different health boards, we had already started to implement things like nurse toothbrushing before ChildSmile came in. And it wasn't until ChildSmile came in that it became a universal provision. And that improvement has continued up until the survey that was just reported last year. So, certainly in my practicing lifetime, a good result for 5-year-olds in Scotland. ChildSmile, even before they get to primary school or even nursery school, they get dental packs sent out, fluoride toothbrush and toothpaste. And by the time they're 5, they should have received 6 of these at home. This goes out to every child in Scotland, roughly about 60,000 children born every year in Scotland. And this toothpaste was given out. I was a member of the mountain rescue team when I was up in Inverness, the Cairngorm Mountain Rescue Team. I was also a member of the team when I was down in Manchester, down in Oldham. I was in the mountain rescue team there. Anyway, I was up in the mountain rescue team. There was various training weekends, And one weekend I was across in the west coast of Scotland at the other team that's over in the west of Scotland, can't remember the name. We were staying in a big bunkhouse, all the team members, to do training for safety and all the rest of it. And I can remember getting ready to go to bed, and everybody's toiletry bag was there. And I noticed that some of these men, mainly men, who, well, I was in the men's toilet, so it was certainly the toilet bags for the men. And I noticed one of them had a ChildSmile toothpaste tube in it. And it was then that I realized we were getting toothpaste out into the community. Sometimes the children weren't using it. In this case, obviously one of the fathers was using it. But that toothpaste was getting right out to every child in Scotland. And in Scotland, we have universal nursery provision. Every child between 3 and 5 years of age, if they want it, every child can go to a nursery school. And I can't remember the exact hours. I think they get 30 hours of nursery education a week, or 30, maybe it's 35 hours. I can't remember. But every child in Scotland gets nursery education if they want it. It's universal. And I think that's one of the reasons why ChildSmile has been so effective, is because every child has benefited from it. We get supervised daily toothbrushing. These are healthy settings. And they also get dental packs to take home with them to use. And some of them get fluoride varnish as well. Excuse me. And they brush once a day in the nursery school. So for children that are already brushing at home, brushing once a day may have a marginal benefit. But for any children that don't get the chance to brush their teeth at home, then the once daily brushing in the nursery school will have a huge preventive effect. And I think that's been one of the main reasons why ChildSmile has been so effective in Scotland. There's also ChildSmile practice. We get the general dental practitioners. Practitioners involved. We try and get every child registered with a dentist. We have health visitors and dental health support workers facilitating that. They give out advice to the parents, obviously. The children are quite young at this stage. And they also are supposed to provide fluoride varnish twice a year to the children when they come in for their checkups and so on, once they're over 2 years of age. And ChildSmile practice is definitely working. These are the registration figures from 2017. A little bit cheeky showing these, but we had 105% of 6 to 12-year-olds registered in Scotland. Obviously, statistics are, we just need to be realistic about this. There's obviously been double counting, or the denominator population isn't correct or something. But I don't think we've got over 100%, but we must be getting very close to 100% of children registered in Scotland. At least we did in 2017. So ChildSmile practice is working as well. And this is looking at 11-year-old children. We use the Scottish Index of Multiple Deprivation here. So we're breaking the population down into 10 categories. It's looking at the percentage who are free of caries experience. Category 1 is the most deprived, up to category 10 is the least deprived. The R squared there is 0.96. So 96% of the variation in tooth decay experience is explained by the Scottish Index of Multiple Deprivation. So this is for 11-year-old children. We look at 11-year-olds in Scotland, primary 7 children. Now, this is a slightly more complicated graph. This is looking at 5-year-old children, primary 1 children, and it's looking at the 7 surveys that have been done using the Scottish Index of Multiple Deprivation. We've been able to cut them into 10 categories over the 7 years, and what I've done for each of the years is add in the best fit regression line. I've truncated the vertical axis there, so instead of going from 100 to 0, it goes from 100 down to 30%. And these best fit regression lines give us an indication of the inequalities that we've got across Scotland. You can see there's an inequalities gradient, just the same as for almost every other human disease. And looking between 2008 and 2020, you can see that the line has improved, it's gone up. We know that dental health is getting better, but those lines are pretty much staying parallel, which suggests to me that we're not making much of an impact on dental health inequalities. If we were, what we would find is that that line should swing up. It should leveling up. There we are. That's something that's topical if we were reducing inequalities, but we haven't been finding that with the data that we've been publishing in Scotland. And we got an excellent report recently from Sandra White and Professor Newton. I've forgotten his name. Anyway, excellent report on health inequalities. And this is looking at what's called the relative index of inequality. We've got Scotland on the left-hand side, England on the right-hand side. The way that the index is calculated is different, so don't worry that Scotland and England figures are completely different. But you can see in Scotland that the relative index of inequality hasn't really improved at all. In fact, might be getting worse. And in England, the relative index of inequality has not improved. So even though dental health is getting better in both Scotland and England, it doesn't appear to be, inequalities don't appear to be getting any better, sadly. So what next for ChildSmile? And I suggest, for one thing we need to consider for the future, which you've already got in England, but we don't have any in Scotland, is to consider water fluoridation, adding water fluoridation into ChildSmile. We did have a Scottish Oral Health Improvement Plan published in 2018, which stated that although we recognise that water fluoridation would make a positive contribution to oral health, we can't be bothered to do it in Scotland. And I think it's disgraceful that this Oral Health Improvement Plan was published with this quote in it. But there we are. That's the situation in Scotland at the moment with regard to water fluoridation. We've got a Cochrane review of water fluoridation. The results coincided very closely with the results from the York review about, I think about 10 years earlier. 15% of more children would be caries free. And if we, this is the data from Scotland, it's looking at that 40-year data, that's 37 years. And if we'd fluoridated in 1999 in Scotland, if we'd fluoridated all of the water supplies, which is when Scotland got its parliament, if we assume it would take 5 or 6 years, 6 or 7 years for the benefit to feed through, then our 5-year-olds, instead of having 74%, 73.5% caries free, we would now have 88% of our children caries free. But we haven't implemented water fluoridation in Scotland, but we can use the results of the systematic review to predict what the level would be in Scotland. It's a very crude model, this, but it gives you an indication of what could perhaps have been achieved if we'd fluoridated water in Scotland. And you don't need me to tell you about the return on investment that Public Health England did. As was mentioned in the introduction, I'm a member of the British Fluoridation Society, and when I was training, it was kind of almost expected you'd be a member of the British Fluoridation Society. I would encourage you all to join. You can join as an associate member for free. You get various updates and so on, or you can become a full member where there is a fee. I can't remember exactly what the fee is. But again, it's tax deductible, so I would encourage you to join the British Fluoridation Society if you can. And that is the end of my chat. I believe we now have a question and answer session. Thank you for listening.
Thank you very much, Colwyn. That was a really interesting presentation spanning, you know, the whole of your career and at different high points. So really interesting. Ross, did you want to say something about the timing? I know you put it in the chat. Did you want to say anything?
Yeah, just to say that we are going to have a question and answer session now, and although we're at 7:30 already, people can hang on and are willing to. We're going to have 15 minutes now, just going through a few things. And obviously, if you can't stay because you've made other plans, then the session will be available on the YouTube in the next couple of days.
Absolutely. We don't want to cut things short, so we'll have some time for questions. Just while everybody's thinking about questions that you want to ask Colwyn, and we'll open it to the floor shortly. But we did have a number of questions that came through prior to the masterclass this evening, and I've got a list of them here. So I'll kick off and ask one of those that's come through from our members. So you were talking quite a lot at the end of your presentation about ChildSmile and the different elements to it, so the practice element, the nurseries, the schools, etc. And one of our members just wanted to know how would you get settings involved if they initially decline and they don't want to participate? How would you sort of approach a setting to try and convert them to participate in ChildSmile or a similar kind of program? Okay.
It's a very good question, and we did actually have problems with a number of nursery schools and so on. The universal provision of nursery education to children in Scotland was something new, and I think perhaps that quite a large number of nursery schools didn't know what they were going to do with the children. So getting them to brush their teeth actually, for them it was quite it was a good thing to do. It's personal grooming, it's entirely appropriate and so on. You've got to remember, we were also giving them free toothbrushes and toothpaste. We had dental health support workers going in to help them, and we also used the nurseries to distribute the packs that they would take and use at home. But we did occasionally get nursery schools where there was just blank refusal to take part with that. And I can remember at the time we'd do, certainly when I was working in Edinburgh, in Lothian, there were 2 occasions where they just refused to take part. And I went to see the Director of Education, I can't remember his name, and he listened very patiently, and he said, right, Colwyn, so what's the problem here? We've got 2 nurseries, and all the other 387 nurseries were participating. He said, you just tell me which are those 2 nurseries. And, I mentioned it to them. And very quickly, both of those nurseries took part. They joined the scheme. I have to say that the head teacher in both of those nursery schools left. Oh, well. And my experience was that there was actually other problems in the nurseries. There was other things going on with the staff or the buildings or something. And, ChildSmile, it was just one thing too much. Almost everybody took part. And when we did get problems like that, going to the Director of Education sorted those out. And, I don't know what was going on in the nurseries. I don't know the inside story, but all of a sudden there was a new head teacher and they were more than happy to take part.
Yeah. Directors of education can be very useful people, can't they? If you get them on side, they can really make a huge difference.
Sure. And we thought we'll just get them to write to all the schools, which of course you get a directive from people, it just pisses people off. Whereas, there was a specific problem with that nursery. We looked into it, and there was some, local thing going on. We also, there were attempts to produce more, install more basins for them to brush their teeth and rinse and all this kind of thing. So there was all sorts of schemes going on. But the support, the dental health support workers that went in were really good at pushing that forward.
Yeah, so you almost needed 2 levels, don't you? You need the dental health support workers on the ground, and then you need the Director of Education. You kind of come at it from a 2-pronged attack.
Yeah.
Okay, thank you. I'm just having a look at the chat here. I can see Anna, you've got a question for Colwyn. Did you want to ask your question? I can put it forward for you if you prefer.
Yeah. Sorry, just had to find the mute button. Hello, Colwyn. Thank you for that. My question was around your point and your comment about how I think you used the word disgusted you were about the comment about water fluoridation in the oral health strategy. And I just wondered whether, since that had been published, there'd been a change in appetite, particularly government, to water fluoridation, or whether it's still the same sort of attitude towards it.
As far as I'm aware, there hasn't been any change. This is a Scottish oral health action plan, And as far as I'm aware, there hasn't been any change in government attitude in Scotland. I was very interested to hear that in Westminster there's talk about trying to promote water fluoridation. And we may just have to rely on the fact that if England starts to expand the amount of water fluoridation that they have, covering parts of England, that eventually the Scottish Parliament will sit up. And health's a devolved issue in Scotland, so that's the issue. I mean, the reason I'm disgusted is that they had a consultation, people sent it, and saying that they should fluoridate the water supply and all the rest of it, and they just completely ignored it. There we are.
Thank you.
Can I ask a question related to that? You mentioned about levelling up in your presentation, and I was going to ask you what you think would be the best way for us to go about trying to level up with regards to oral health. But I'm guessing you might say fluoridation, but I was wondering if that is what you're going to say, but also if there was anything else.
I think we should tackle child poverty. I don't think there's any doubt about it. It's it sounds trite to say it, but it's crazy that we've got such high levels of child poverty. We're a rich country. That's what we should be doing. All water fluoridation is going to do is level the playing field a bit. It doesn't get rid of health inequalities. All it does would be to level the playing field a bit, so that we could work on other things and so on. But child poverty, addressing just poverty in general, pensioner poverty, in work poverty, there's things that we should be doing to try and improve the, not just for the children, but for, everybody across society. And the benefits wouldn't just accrue to oral health, there'd be general health benefits, there'd be educational benefits, the population would be healthier and so on. It just seems obvious to me, but the government policy, that's what they decide and so on.
Yeah, and that's exactly the same message that was coming out of Richard Watt's presentation in the last masterclass, and I suspect probably a lot of us here listening would agree with you. I think there's another question from Ken Eaton. Do you want to ask your question?
Yes, thank you very much, Charlotte. Colwyn, I really liked your presentation. Thank you very much. The new leader of the Scottish Labour Party is a dentist. In fact, I think he was on the GDC at one time. Is there any possibility that he can be stimulated to help move things on in all areas, but particularly with water fluoridation?
Thanks, Ken. Good to hear you, and thanks for your comments there. Yes, I've already met Anas Sarwar. He, as you see, he qualified as a dentist in Glasgow. He supports water fluoridation, but I think he's got other issues on his plate at the moment in Scotland, just trying to get the Labour Party kind of re-established up here. They're not doing terribly well at the moment. But I know that he is supportive of water fluoridation. I think initially, because he's a dentist, he didn't want to get stuck with all the dental issues type thing when he first got into the Scottish Parliament, and he almost kind of distanced himself from dentistry and from oral health and fluoridation and so on. But I have met him a couple of times, and I don't know if I'll get the chance to meet him now. I know he'll be pretty busy with things, but if we can lobby him, it would be great to be able to influence him. But we've just had an election here, and the Scottish National Party and the Green Party, who are both independents, they're both in favour of independence, and don't actually seem to be in favour of water fluoridation. So I'm not sure how effective we're going to be. We perhaps need to work with people in power in government rather than people in opposition, Ken. But it's a good idea, and we are working on it. I'm just trying to reassure you, I suppose.
Well, I think they're all interested in inequality. They're all talking about better education and better social care. So maybe that's the way into them.
Indeed, thank you. Yes, we'll pursue that.
Absolutely. And Esther, have you got a question that you wanted to ask? I can see you've put something in the chat. Oh, I don't know if you're talking and you've got mute on, or whether you want me to put the question forward for you. I'll give you a second or two.
Thank you. I was on mute. I was talking to myself. Thank you
Well
so
done
much.
it.
Thanks. Thank you so much for this thought-provoking presentation. Just wanted to double check about when you discussed about the impact of ChildSmile on reducing inequalities, because checking the latest publication, it does suggest that there is some impact on reducing inequalities, because it says that children in areas of high deprivation seem to get the most benefit. So can you please comment on that? Thank you.
Oh, okay. I obviously I don't know what you're quoting from there. The systematic review of fluoride toothpaste showed that fluoride toothpaste is more effective in areas where you've got higher levels of tooth decay. So you would expect with the nursery toothbrushing that the absolute reduction in tooth decay is going to be higher in areas of deprivation. So the SIMD 1, 2, and 3, and so on. The relative index of inequalities, the RRI, the table I showed you there, is the measure of relative inequalities. Perhaps I should have said that rather than talking about absolute inequalities. I'm talking about relative inequalities here. And the relative index, I'm not saying it's an easy thing to change, but to try and move the relative index of inequalities is very difficult, as we find both in Scotland and England. So children do benefit, if they've got more tooth decay, obviously they do benefit from the preventive effect, but using this indicator, this relative index of inequalities, we haven't been able to show any improvement in the relative difference, if that answers your question.
Yeah, thank you very much. Would you publish this?
It's already been published. It's published in the surveys that are published by the Information and Statistics Division of the Scottish Government, and the English paper I showed you, the one by Newton and White that was published by Public Health England, has got that information in it. So the information, this isn't stuff I made up, this is stuff I've gleaned from other publications. So it's already out there in the public domain.
Yeah, thank you. I meant with regard to Scotland rather than England.
Yeah, the Scotland data is published, yes. It's in the Information and Statistics Division of the Scottish Government. If you type in ISD, Information and Statistics Division, and go to the dental reports, you'll find that information is already there.
Thank you very much.
Okay, now I'm just very aware of the time, and obviously we've gone over a little bit, but I think it's it's important to have this opportunity to ask questions. I know Jennifer Rogers, you've had your hand up for a while, so perhaps if we can take your comment or question, and then if there's anything else that we need to follow up, if there's other questions, I can see that there's a couple of other hands up, then we can follow them up afterwards. But I'm just very aware that we said we would go over by 15 minutes, and I don't want to sort of push that any further. So Jennifer, do you want to ask your question?
Thank you very much. Hi, it's Jennifer Rogers. I'm one of the co-directors of the ChildSmile programme in Scotland, and it was really nice, Colwyn, to see you again and to hear your presentation. It was just a quick comment, and I don't want to take up everybody's time, but in response to what Esther had asked about the sort of roads that we had made in the inequalities in the programme already. So obviously reducing inequalities was one of our key outcomes, and we have made some small roads, some small improvements. And Esther, you were just asking about publications and things like that. We've got our Protecting Teeth at 3 publication, which did show that within the background of the ChildSmile programme, some of our interventions like the fluoride varnish did have, although it was a small effect, it did have the biggest effect in the most deprived communities. And that's what we certainly find with some of our interventions, because we do look at sort of the individual, the community and the national policy. And I think we are over the next while in ChildSmile sort of increasing and refocusing our efforts at the community level, because that's where it's going to have the most effect at the inequalities. So there is a lot of work being done for that very point at that level. We have got loads of publications, and we can certainly share them after this in the chat, and I can send them to you, Maria, if we want to put them on for people. But we can give you the most up-to-date work that we have done in ChildSmile, if that would help. Thank you. Thank you. I think we'll bring the questions to a close there, because otherwise I think we could go on and on asking questions about ChildSmile. It's such an interesting programme, and I think there's such a lot to learn from it. And some of the data that you presented, Colwyn, has really sparked people's questions, you know, about potentially replicating similar things elsewhere. And we know we've got similar programmes in other parts of the UK. So if anybody has any questions, if they want to send them in, then we can make sure that they're answered, so everybody gets the information that they want. So apart from that, I just wanted to thank you very much for your presentation, and thank everybody very much for their questions. And I'll hand you over to Ross.
Let me just take myself off mute. I'm just going to unmute myself. There we go. So I think you'll all remember last time that we finished off just giving a little bit of information about joining BASCOD. Obviously, we want to be able to keep giving these presentations and these masterclass sessions, but it might not be possible to do that in the future for everybody, including those outside of the BASCOD membership. So on the screen here, I've got a QR code and a little bit of information about BASCOD, what the organisation stands for, and how you might be able to help us. I think it's really important to note that we're not an organisation which is specifically for those with a clinical qualification. So we're looking for people to join. Anybody who's got wants to make an impact on population oral health and improve oral health inequalities. We're looking for people like you to join us. So like I said, the QR code is just there. And the second thing to bring attention to is that this masterclass series, it's a series of 3, and so we've had the presentation from Richard Watt and today from Colwyn. Our final presentation in this series is from former Deputy Chief Dental Officer Eric Rooney, who I worked with in the Northwest very recently. So I'm very much looking forward to this presentation. So again, if you'd like to scan the QR code on here, you'll be able to sign up for the event, or we will be sending out the details through the normal channels. So I'm just going to leave this on the screen. I want to say thank you very much again to Colwyn, to Maria, to Charlotte and to Alona for helping with this masterclass session today. I think it's been absolutely great, and I look forward to seeing you all at the next session. So thank you very much.
Sorry, I'm muted. Thank you, Ross. Thanks everyone for joining us. Have a good evening, and we will be having hopefully a second series of masterclasses in the autumn, and watch the website for that. But thank you very much, Colwyn, for tonight, and we're looking forward to Eric's talk in June. So good night, everybody, and good evening, and thanks for